All right, everybody. So, welcome to our Health Policy and Bioethics Consortium, our first one of 2005. We only have an hour together, and we've got a lot of really interesting material to cover. So, my name's Erin Kesselheim, and I'm with the Center for Bioethics as well as the Portal Program on Regulation, Therapeutics, and Law. And want to thank you all for joining us today. This will be an hour-long session. We are going to uh, have some presentations from some of our panelists and then open up to questions at the end. And I will turn it over to my colleague Leah Rand, who's been organizing these with me to introduce today's session.
Thank you. So the aim of this session is to explore a current issue in healthcare and policy and think about both its ethical implications as well as what policy could maybe improve the situation. And so we hope that this sparks some good conversations amongst all of us. And sorry, that should have been March 7th. We'll convene for our next panel on AI in healthcare. But today I'm really pleased to welcome today's speakers. And I'm going to start off by introducing our moderator, Hussein Lalani. Hussein is an instructor of medicine at Harvard Medical School and a primary care physician at Brigham and Women's Hospital. His research focuses on health disparities, equity, and policy centered on healthcare access. He's the co-founder of This Is Our Shot and Vakunete Ya, a national grassroots social media organization that elevates the voices of trusted medical professionals to build healthier communities and combat health misinformation. He was named a Stat Wunderkind in 2022 for his work on improving access and affordability to healthcare for all Americans. I'm also especially pleased to welcome him as he is a former fellow and colleague at Portal, and I'm going to turn it over to him.
Thanks, Leah. It's great to see you, and welcome everyone to today's session. I'm excited to be your moderator. I am not going to be doing very much here, actually. The stars of the show are the two fantastic presenters that I have the honor of introducing and learning from with you. So we'll start first with Dr. Zirui Song. Zirui is an associate professor of healthcare policy and medicine at Harvard Medical School and a general internist at Massachusetts General Hospital, where he practices primary care and attends on inpatient medicine teaching service. Dr. Song's research focuses on the health and economic implications of financial incentives, public policies, and other changes in the healthcare system. He has worked on Medicare payment policy at the Department of Health and Human Services and on public health issues at the Brookings Institution. He served on many national committees, including the National Academy of Sciences, of Engineering and Medicine. He's also locally served as a visiting fellow at the Massachusetts Health Policy Commission and on the Massachusetts Medical Society Task Force on Healthcare Reform. And he is the associate editor of JAMA Health Forum and an editorial board member of Health Services Research. We are thrilled to have Zirui with us and excited to hear from him first. Before I hand it over to him, I also want to introduce our second presenter, Erin Fusay-Brown. She's a professor of health services, policy, and practice at Brown University School of Public Health. She was previously the Catherine C. Henson Professor of Law and Director for the Center for Law, Health, and Society at Georgia State University. Professor Fusay-Brown's area of research and expertise includes healthcare law and policy, healthcare finance, healthcare consolidation and prices, and the Affordable Care Act, including single-payer and public option health reforms, ERISA preemption of state health laws, and consumer financial protections for patients facing surprise medical billing and medical debt. She also serves as a consultant to the National Academy for State Health Policy, or NASHP, and she provides legal and policy resources and draft model laws. And her work has influenced healthcare policy at the state and national level. As you can see, both of our presenters are the leaders in their fields when it comes to private equity and healthcare. And so it's a real treat to learn from them and engage with them today. I'll turn it over to you, Zirui.
Thank you so much, Erin, Leah, and Hussein, for your kind introduction. And I'm honored to be here with our colleague, Erin. Let me share my screen. Is this visible for you? Great. The issue of private equity in our healthcare system has emerged in recent years, largely through several publicly salient events involving hospitals. These are examples of hospitals across the country that have undergone some sort of bankruptcy or closure process, which has elevated the issue of private equity involvement more publicly. We want to just cover the basics of what a private equity acquisition is. And using a diagram here, I'm going to lay out the basics of the so-called leveraged buyout, which is acquiring a healthcare entity with largely borrowed money as opposed to existing dollars from investors. But we'll start here on the left with a private equity fund. A fund is a pot of dollars. And from that pot, a blue box in the middle, which is a smaller pot, is chipped off as the acquisition price, the amount used to buy, let's say, a hospital or a physician practice. And one of the key aspects of private equity is that in the classic, again, so-called leveraged buyout model, a small share of this acquisition price comes from existing equity or existing dollars, largely from one's investors. Investors are called limited partners. The largest types of limited partners in the US that invest in private equity are public pension funds, institutional endowments, banks, indeed even hospitals, sovereign wealth funds of other countries, and the wealth of wealthy people. If you take this example of a 30% equity and you'll see 70% debt kind of acquisition price, in a classic case, almost all of that 30% of existing dollars would come from your investors, 98% in this drawing, with 2% coming from the parent private equity firm. The other 70%, as noted, would come from a lender of some kind. This could be a bank. Increasingly, this is another private equity firm involved in the transaction. But with this blue box, one would acquire a healthcare provider of various types, hospitals, hospices, nursing homes, practices, as we'll talk about. And the important second distinction here is that the collateral for that loan, that 70% of the acquisition price, comprises the belongings and physical assets of the acquired entity. The stuff of the acquired entity is used as the loan, the collateral for that loan, as opposed to the belongings of the parent private equity firm. A third feature of private equity in this classic model is that after a short holding period, we've often written 3 to 7 years, but there's quite a variation here, the acquired entity is sold again. And at least in physician practices, we've seen that in about 2/3 of the time, it's sold to a second private equity firm. And about 20% of the time, it's sold to corporate owners, other corporations, including insurers. And in about 5 to 10% of the time, it goes public to the stock market. There are examples of corporate owners, many of which we're familiar with just in our day-to-day lives. Another feature of private equity in this classic leveraged buyout is how the dollars or money flows. You'll see here 2 green arrows denoting management fees. The one here on the bottom left is important. These are management fees from your investors back to you for the privilege of having their dollars managed by you and invested by you. Those management fees are typically 2% of the value of the fund per year, even if nothing happens on the transaction side. So investment dollars held silently or held as so-called dry powder would still generate management fees. On the top green arrow, you have management fees, not always, I just want to emphasize, not always, but in some cases coming from the acquired entity back to the parent private equity firm. And that's for the privilege of being managed by the management expertise of the private equity firm. Those 2 streams of management fees added together already typically exceed 2% of the 30% of existing dollars in the acquisition price. In other words, after 1 or 2 or 3 years, after a short period of time, the financial risk of the parent private equity firm in the actual acquisition price has already been exceeded by the totality of management fees collected. This in part explains the so-called risk-taking behavior or moral hazard features of private equity ownership models throughout the years, not just in healthcare, but across other industries. Private equity has been around in the US since the 1980s. It's grown quite quickly through many industries, the service sector, manufacturing, consumer goods, telecommunications, just to name a few. And after 25 years or so, 20 to 25 years, it made its way into healthcare for the last 2 decades. On the left, you see a map here of dots showing you using 2018 data where hospitals owned by private equity are located. And I'm going to use that to contrast in the next slide of how quickly those dots have multiplied just in a few short years. So hold that in your mind with 2018 data. And on the right side is a map showing the penetration of private equity firms into physician practices, with darker shading denoting higher levels of percent physicians owned in a particular area. Going first to hospitals, this now is the number of dots analogously on the map. 460 hospitals that many public sources have cited. Not all of these are acute care hospitals. I just want to make a note of that. There are long-term acute care, LTACs in here, other types of hospitals. So these are not the canonical major acute care hospitals we tend to think of. But 460, if you take that number, roughly 8% of all private hospitals are represented by these. They also account for 22% of for-profit hospitals in the US and serve slightly over a quarter of our rural people in the country. On the physician practice side, if you take that same map and now look over on the right side, our colleagues at Berkeley have published newer data showing just in these 2 short years, you go from a 2022 paper to a 2024 paper, and essentially the penetration, although I don't have percentages on the left here, but the penetration into physician markets in terms of private equity ownership has also grown quite rapidly. It's marked by growth in procedural specialties, tends to be high-priced procedural services that can be done quickly on the outpatient side. These kinds of specialties like GI and urology, and to some extent derm and ophtho, tend to get acquired first. But we're also seeing a lot of primary care and behavioral health acquisitions. So it's really more generalized across the board. And just a spot check at other parts of our delivery system, women's health here, nursing homes here, hospices here, and opioid treatment programs here. Much of this work was led by colleagues here in our institution and also across the country. I just want to recognize and really credit folks at Hopkins, Brown, Penn, Cornell, and lots of other places. And even within our institution here, many great colleagues at the BI, the Smith Center, the Brigham, colleagues at Mass General have worked on this. So really a collective body of work across a large group of academic colleagues. And I just want to highlight a couple of specific papers here and try to focus on the newer evidence. This is one of the initial papers led by Joe Bruchnow, professor at the University of Chicago, that he did here when he was a graduate student at the School of Public Health, and basically studied about 200 hospitals that were acquired by private equity versus about 530 controls, and showed that in a representative graph here on the right, with the 0 on the horizontal axis at the time of acquisition, that in the 3 years after acquisition, private equity hospitals are able to demonstrate 27% increase in net income, driven largely by an increase in charges. Those are the asking prices, and a change in case mix, as well as a shift towards more commercially insured patients and away from Medicare patients. Case mix is documented complexity of the admission, not necessarily an ICD coding issue, but here it's more specifically the DRG that one would pick based on severity. We followed up that work, which did look at process quality measures, but process quality measures being highly imperfect, with another study led by now a colleague at the University of Pittsburgh, Sneha Kannan, who did her fellowship here, on adverse events and hospitalizations, similarly across 3 years versus matched controls. We found here a 25% increase in hospital-acquired complications. These are not process measures that one could check off on a checklist or automate as a default on a discharge summary, but rather these are preventable harms that have to happen in hospitals to be picked up in the claims data. They can't be present before admission. And this was driven by largely an increase in central line bloodstream infections, or CLABSIs, despite fewer central lines being done. Also, part of the result driving this was a doubling of surgical site infections despite fewer surgeries being done. That subgroup result was less significant, but it drove the overall average. And what also drove the overall average was a 27% increase in falls, all relative to the control group. What we also found in this work was that people admitted after private equity acquisition were healthier on average because they were younger and less likely to be dual eligible for Medicaid, so less likely to be disadvantaged. If healthier is too strong a word, probably a better word is lower risk for subsequent complications, for subsequent spending. So despite on the margin lower risk population of admissions, the differential increase in these complications was quite worrisome. Another reason it was a lower risk population was that all of these complications happened after a 12% increase in patient transfers. out of the hospital to begin with. And as we all know, working in larger academic centers, it tends to be that sicker patients are transferred out. Healthier patients don't really have an opportunity often to be transferred out because receiving hospitals tend to receive only the sickest patients. So among this healthier subset who remain already younger and lower risk to begin with, we're finding these increases relative to the control group. Extensions of this work currently under review showed that in the EDs of these hospitals, so downstairs, if you just look in the ED, there is this differential increase in ED mortality. Thankfully, ED mortality is low to begin with. Most people walk out of the ED alive, thankfully. But off of a small base, a small change can look like a big percent change. So don't want to blow this bigger percent change out of proportion here, but it is, as you can see on the left, a separation from the control line. Similarly to the prior study, most US hospitals in recent decades have been getting safer just because the general hospital safety movement, checklists and washing hands and all the things we see in hospitals, that has generally led to lower mortality in hospitals, in EDs, just a small secular gradual decline in complication rates. But it is against that backdrop that the private equity trends on average tend to separate in the other direction. So similarly here with ED mortality, and again, happening after a 20% increase in transfers. So presumably already the sicker patients having been transferred out, and these results on mortality being among the healthier subset that remains. What explains this? We believe the chief culprit is likely staffing cuts. And so in other work also under review here, we're finding a roughly similarly sized magnitude reductions in ED salaries and also in ICU salaries, places that are very, places where outcomes are very sensitive to staffing. And this is similarly magnitude in terms of total FTE cuts across the hospital. Across the country as a whole during the study period of this little blue line here at the top, total staffing in US hospitals is going up, that is for sure. But again, at private equity hospitals, we're finding they're not going up, but rather going down. On the physician practices side, this is work led by Yashaswini Singh, a graduate student at Hopkins at the time and now a professor at Brown University. We are finding a similar type of story, comparing physician practices acquired by private equity right here, the dotted line, relative to the controlled practices here, larger sample size, but smaller units, obviously smaller practices, not bigger hospitals. We're finding this 11 to 20% increase in charges/prices, so either the asking price or the negotiated in-network commercial price. We're also finding an increase in volume. So not only did price go up, volume goes up. And since price times volume equals spending, society spending on this care is certainly going up. Volume going up may not be a bad thing. It's really about how appropriate the volume is. But one curiosity here is the coding of long visits. So there was an increase in long visits, as well as an increase in more people and more unique people seen. That could be a good story for access. But as we're finding similarly to the hospital setting, we found staffing cuts among physicians here in these practices after acquisition. Now, there is a replacement of higher cost forms of labor, i.e. physicians, with lower cost forms of labor, i.e. our nurse practitioner and physician assistant colleagues, without whom in this clinic here at Mass General, where I am at the moment, we certainly would not be able to operate. So this is not a normative statement about the value of advanced practice providers. They are critical. It's just, it seems to be a substitution for the cost of delivering care, that higher cost forms of labor are being replaced by lower cost forms of labor on the margin. If you believe that reduces your capacity to deliver care, which doesn't necessarily have to be the case, then it does seem curious that you get this increase in long visits along with more people. There are only 24 hours a day. So to see more people and everybody seen for longer on average, and you have fewer hands on deck, or at least perhaps smaller panels, that seems to be a potential contradiction and maybe a coding effect. We're also finding that private equity firms have, they're showing a larger increase in professional fees here on the left in a paper that just came out, led by also colleagues here, Brown, Oregon, with Jane Zhu at Oregon, in part leading this work, where it sort of distinguishes private equity from other health system forms of acquisition. And so, as I'll show a little bit later, this is sort of a bit of counter evidence against a pushback that private equity is no worse than health system acquisition. On the right, we're showing that there are other mechanisms for driving up revenue and thus returns for one's investors. This is an example of using expensive drugs, physician-administered drugs, at least in this ophthalmology setting. In nursing homes, our colleagues at Penn and elsewhere at NYU, for example, in this paper, have found a fairly large increase in ED mortality related to a reduction in patient experience and a reduction in staffing in nursing homes after acquisition. So I just want to quickly go through before closing here a few pushbacks. These are common rejoinders that we have heard from either the private equity industry or academic colleagues who have also looked in this area. So one is, if not for the private equity funding, healthcare institutions, hospitals, nursing homes would have closed anyways, because they were already financially struggling to begin with. And so private equity financing should be seen as more of a savior as opposed to a harm. Because they're bringing in private capital where institutions need it. Institutions cannot find this capital off the Medicare fee schedule. They can't negotiate it off of commercial insurers. Medicaid is not providing more money. So where are they going to find the money they need? Here's a private source of capital. And so it's a good thing. And it turns around struggling businesses. This is so-called distressed investing. And our general sense of distressed investing is that you can definitely find anecdotes where it is true. And I think it is true in many compelling stories where there can be win-wins. The private equity firm and their investors win, and the business that got acquired got turned around. But in the grand scheme of the pie of private equity acquisitions, distressed investing is perhaps, I'm going to take a guess just based on, I think, what people have studied and written about private equity, maybe 2 to 5%, maybe a little bit more of the total share of private equity acquisitions. The vast majority of acquisitions are made using the acquired entity as a vehicle for short-term returns, as opposed to turning around that vehicle that was struggling. We looked at this question with hospitals, and we found that on average, hospitals acquired by private equity firms before acquisition were not financially struggling more compared to their matched controls. Matched controls being hospitals that looked alike but never got acquired. The ones that ended up being acquired were actually on sounder financial footing in terms of how much of their goods they actually owned as their own equity. Their operating margins, their earnings were not worse, and their clinical performance was not worse. It did not look like that on average, that anecdote is true. The anecdote of distressed investing is certainly true in some cases. It just does not seem to be true on average. On average, it is the acquisition of healthier hospitals. And that makes a lot of sense because you're placing additional debt onto the hospitals you acquire. And would you rather buy a hospital that's struggling and perhaps would not bear the weight of the additional debt well? Or would you rather buy a hospital that could bear the weight of additional debt and still generate revenue for you? So this makes sense for us. Second pushback is that private equity firms are not monolithic and they do not do all the same thing. This is true, and I'll just quickly go through this. In this work, we do find that, oh, no worries. One of my colleagues just walked into clinic. In this work, we're finding that not all private equity firms behave the same way, specifically that hospitals acquired by Hospital Corporation of America, which was the first large acquisition, tended to raise their charges more as opposed to cutting their staffing. The subsequent acquisitions by all the subsequent firms that we could identify tended to cut their staffing more as opposed to raise the charges. So there are various ways to generate profits. You could raise prices, you could raise quantities, or you can cut the cost of delivering care. Turns out if you cut the cost of delivering care, you've got less hands on deck and less ability to raise your volume. So it comes down to largely price increases versus staffing cuts. And we're able to show that different firms do take different strategies along these lines. So that's what these graphs are conveying, HCA versus other firms, anonymously labeled. And my final slide here is simply that physicians feel about private equity firms in potentially strong ways and relative to other forms of ownership. Not to go into this in great detail, but basically relative to other corporate or for-profit forms of ownership, private equity acquisition is felt to be more about the same and just subjectively. But relative to independent physician ownership, physicians tend to say that private equity acquisition or ownership is worse. And they're also stronger feelings about what aspects of healthcare delivery private equity firms affect in a positive or negative way. Okay, let me turn it over to Erin on this slide, which is a quick table summarizing the policy levers available to state and federal policymakers. Erin will take us through her version of this in a much more detailed way. This is a simplified table listing some of the policy levers available. Thank you so much, and over to you, Erin.
Thanks, Zirui, and what a wonderful kickoff to, to this talk. Zirui and I have done this, a version of this presentation many times, and so it's always a pleasure to talk about this topic with Zirui because he really does frame the issue so well. And I will be now sharing my screen to talk about the policy levers, and I'm going to focus on the state policy levers just because we only have so much time. And so I'm going to be talking based on some work that I've done with the National Academy for State Health Policy, as was mentioned in the introduction, that I'm a consultant for, but also wanted to give a shout out to my colleague Hayden Rook-Lay, who's a fellow at Brown, a law and policy fellow. I think Hayden's mom is on this webinar. I think so. Just like I feel like a Peloton instructor. I'm just like giving shout outs to people in the audience. So but yes, so the two of us worked with with NASHB to develop a series of options for states who are really trying to respond to these trends. And they're trying to respond in real time. And in some ways, states are more nimble than the federal government. We can have a conversation later about some efforts at the federal level. But I think states are also able to move quicker in some respects than the federal government. And so what motivated this work was states approached NASHB and said, we want some policy tools, we want a toolkit, and we really are concerned. And we're hearing from our constituents that private equity in particular, but other forms of corporate investment is consolidating our healthcare space. We're worried about some of the effects on access, on equity, on not just on prices and spending, obviously, but that too. And so this was really just a concerted effort to give states some options to address some of the corporatization that's going on in their borders, but also the consolidation and sometimes the closures or other untoward effects that occur as a result. So without further ado, the NASHB model really takes a three-pronged approach. And this was just, again, looking at some of the levers that states already had, but also trying to see how we can enhance those oversight tools to reach this sort of new form of consolidation and the entry of private equity. So, for example, a lot of states have been experimenting with expanding their ability to oversee transactions, both from an antitrust perspective, but also for sort of larger public interest and health care concerns. So to expand on a state's healthcare oversight authority, as well as to deal with the sort of consolidating effects of the market that often these transactions involve. But look at the effects they have on costs, on access, on closures of service lines or facilities, and also take a look at the particular strategies that are being used, particularly the sale leasebacks that we saw involved in the Steward Healthcare debacle, but also this is a common strategy that's used across private equity investment in facilities in particular. And then the second part of the sort of the policy puzzle is to protect the clinicians, the workforce that are involved in these acquisitions, and to strengthen longstanding doctrines of the corporate practice of medicine to, again, shield physicians and their clinical decisions from some of the profit-seeking incentives that corporate investors and private equity investors have typically put on the clinicians involved in these transactions. A third option is to increase the transparency of ownership and control entities because we can't study and we can't understand what we can't see. And so a lot of states have been interested in what would it take to do that. So I'm going to talk about each of these in turn. So the first part of the NASHB model really talks about the enhancing the oversight authority of the state through enhanced transaction oversight. As I mentioned, often this was traditionally done through the Attorney General's office through antitrust review, but increasingly states are feeling like that authority needs to be supplemented by sort of healthcare expertise within a healthcare agency. Another concern is that traditional antitrust tools at the federal and the state level tend to miss a lot of these transactions because they're simply too small to trigger reporting under mandatory federal standards of deals, which number, it's close to $119 million is the deal size that triggers reporting. And you can imagine a lot of, say, physician practice acquisitions or clinic acquisitions, behavioral health, these simply are too small to ever be reported to any authority, federal or state. So states are lowering that threshold to have more visibility into these transactions. In addition, the state is also worried about, states have been worried about not just missing small transactions, but missing transactions that involve sort of novel forms of investment, including private equity, insurers, and the like. A lot of states have traditional authority over nonprofits through their charitable trust authority. And so they might see when a nonprofit hospital is acquired by a for-profit entity, but they may not have any sort of levers or tools to oversee the transactions involving physician practices, for example. So states wanting to strengthen this authority in a couple of ways. There are two primary ways that states are doing this. One is to expand the actual authority of what is involved in oversight, to require prior notice of a larger number of transactions, any transaction, sort of no matter who it involves, but not just restricting it, for example, to nonprofit hospitals. Expanding the authority to review, to basically request information from the transacting parties, to pause the transaction while this review is undertaken, and to be able to do a comprehensive review along a number of factors, not just the impact on competition and prices, but also on things like access, quality, workforce, and equity. And then the authority that some states are actually looking for is the authority to seek to block or impose conditions on transactions that they deem to be worrisome without having to necessarily go to court or asking the state attorney general to decide which transactions to litigate to block in court, because it's a lot more resource intensive to convince a judge to block a transaction rather than an administrative entity that might have done a comprehensive study and decides that there are either enough concerns to warrant blocking or imposing conditions. Another, as I mentioned before, another way that states are looking to do this is to expand the role of state health agencies. And Massachusetts, of course, is one of the originators of this model with the Health Policy Commission's involvement in reviewing these transactions. And other states are following similar models, or again, placing a significant amount of this review authority and the ability to study transactions and then to provide oversight on an ongoing basis in an entity that frankly has an agency that has healthcare expertise, as opposed to just sort of markets and competition. Not every state's AG's office has dedicated healthcare market staff, and they may not have the sort of interest or the bandwidth to perform the level of oversight that a state might need. So in order to address these concerns, NASHB looked to a lot of the examples from states that have done just this, which is to expand healthcare oversight. And so the main ways in which the NASHB model expands healthcare oversight, one, it builds on a prior NASHB model that looked at states like Massachusetts, Oregon, California, and others that had really thought through carefully what it would look like to build enhanced oversight authority over healthcare transactions in particular. But also this year's sort of updated model law deals with these issues that there were still transactions, even in Massachusetts, even in some of these states that were falling through the cracks. And those are the ones, again, involving specifically private equity entities, these smaller transactions that involve contractual acquisition or controls, whether as opposed to outright mergers and acquisitions. So management service organizations and the sale leasebacks involving the real estate assets of these entities were not specifically called out, so often they were evading review. So it expands, the NASHB model would expand the scope of entities that are subject to review to include private equity investors, management service organizations, which are often the sort of management company that the corporate investor creates to manage and provide investment vehicles for physician practice acquisitions in particular. And these real estate investment trusts that acquire the land and lease it back to the facilities, as well as payers like United that have a large provider acquisition arm as well through Optum, and staffing companies and other types of entities. It also expands the scope of transactions that are specifically required to submit notice as a material change transaction, and those include sale leasebacks, these real estate sale leasebacks, management service organization contracts, and serial transactions going back 5 years, so that, again, these small acquisitions can be evaluated in their cumulative total, because that sort of roll up and add-on strategy is sort of a hallmark of a particular in the physician practice space. Joint ventures, closures would also be considered a transaction, that because it's an outcome worth watching. So to be able to notify healthcare authorities in particular of a planned closure, not just of a facility, but of key service lines, and also staffing agreements. It also, there were also some sense that there was probably inadequate in the original NASHP model enforcement authority to enforce compliance and oversight on a long-term basis. So it bifurcates the enforcement, gives some enforcement authority, obviously, to the Attorney General, but also to the state health agency, who may be able to detect risks and harms that might be occurring, or if conditions were imposed on a transaction that conditions aren't being satisfied. And then to provide ongoing monitoring, again, moving forward on those transactions that are allowed to move forward. So the state example that I have here, pardon me, is the recently enacted Massachusetts law, the Act Enhancing Market Review Processes. So, of course, in the wake of the Steward crisis, there was a lot of soul searching, frankly, and there was a question of, like, if this could happen in Massachusetts, it could happen anywhere. And so what could be done to plug the holes that allowed the Steward, the fate of the Steward hospital system, to really sort of not be caught in time to really prevent some of the worst effects. So this would expand, this legislation does expand the transactions and entities subject to Massachusetts material change notice requirements. So there is a prior notice requirement, right? These transactions must be reported to the Health Policy Commission. And these transactions specifically now include those involving significant equity investors. And then for those significant equity investors, if they contract with or involve providers, healthcare facilities, but also provider organizations like medical practices, and also carriers, meaning insurers, those would all be considered significant, material change transactions that would be subject to notice and review. And it also explicitly extends this notice to sale leaseback arrangements and for-profit hospital conversion. So if a hospital is going from nonprofit to a for-profit status, then it would need to be notified as well. It also, the legislation amends the market share standards for a series of, legal purposes. One is the threshold for notice, as well as the standard of review that the Health Policy Commission will undertake, and the standard to refer a transaction to the Attorney General's office. It changes that standard from one that was a near majority requirement of market share to just a dominant market share. And what this does is it sort of would allow more transactions where the market power of the firm or the firm that's created is dominant, but maybe not approaching a majority in many markets and many subsectors of the healthcare system. You don't really need majority power over a market in order to move the market in a significant way. Sometimes 30–40% is sufficient to be considered a dominant player. And so this allows those transactions to be evaluated and referred. In addition, the Health Policy Commission will consider, as part of its comprehensive review, not only the market power of the entity that exists in Massachusetts, but also the market power of the corporate affiliates, including some of the significant equity investors. So some of these private equity companies, for example, have lots of an investment strategy in many market segments within a state, but also across the country, as Zuri's maps showed, that this is a concerted strategy. And so the use of market power analysis that extends beyond the state's borders and also beyond the sort of stated entity that is involved to extend all the way up to those significant equity investors will capture more of a sense of the national presence of that investor. And then in addition, the Health Policy Commission has a stronger authority to require parties to submit information and also to enforce that with penalties. And to gather not just, again, this sort of price and quality and access data, but also financial health data. So information on the capital structure, the audited financial statements, and again, the ownership and management structure to get a better sense of the overall financial picture involving particularly these very complicated corporate entities or investor vehicles that are often very obscure and difficult to monitor. And then it expands the ability of the state to engage in post-transaction oversight, again, for that 5-year period beyond the actual transaction. So that was just part one. So Massachusetts is sort of really out front in many respects on market oversight, particularly after the passage of this most recent law. But there are also areas with respect to workforce and physician autonomy that merit some additional strengthening as well. And this turns to the corporate practice of medicine, but also other types of provisions that are used in physician employment contracts like non-compete and non-disparagement clauses that can really affect the clinician's ability to continue to use their best sort of professional judgment in caring for their patients, particularly when they are involved in management or acquisitions with corporate entities that have financial incentives as well. So what is the corporate practice of medicine doctrine? So the corporate practice of medicine is a legal doctrine that's long-standing in many states. So these, I think there's, at least 30 states, if not more, that have on their books some form of the corporate practice of medicine prohibition. And what it says in short is that lay entities, these are corporations or individuals that don't have a medical license, cannot own, employ, or control medical practitioners, physicians in particular, but other types of licensed clinicians. So again, although the corporate practice of medicine doctrine might exist in many states, whether it's through case law or through an administrative opinion or occasionally in statute, Massachusetts has a corporate practice of medicine doctrine, for example, the enforcement of the doctrine has eroded significantly over time. And this has coincided with the rise of managed care back in the 80s and 90s and the carving out of exceptions for hospital employment or for health plan employment of clinicians. Most importantly, however, the corporate practice of medicine has really not been able to stop corporate entities from investing in and entering the healthcare market, particularly among physician practice acquisitions, as we saw. There's just been a rapid rise in that investment. Well, why is that? Well, corporate entities have figured out ways to contractually work around the corporate practice of medicine doctrine. For example, a private equity company typically creates a management service organization that doesn't buy the medical practice outright, but simply controls the practice through the management service organization contract to manage and provide administrative services to that practice. Or it does it by installing a friendly physician, someone who does have a license to practice, so complies. It's sort of in the letter of the law, but this person is really not there. It's not involved in the active management or practice in the state. They might often be someone who lives out of state, and they're just a manager. They're someone to be the nominal or straw owner at the top of the physician practice to comply with the corporate practice of medicine, but they are on the payroll of the corporate entity. So what does the NASHP model do? So states are considering ways to strengthen the corporate practice of medicine to get at the management service organization and professional corporations' contractual relationships to each other, to keep the ownership and management control in the hands of the physicians who are actually seeing patients and who are, ethically and morally responsible as well as professionally responsible for the care of those patients. So the first is to just simply add or clarify that the corporate practice of medicine exists and to state it in legislation. And what this does is, again, to just reiterate that unlicensed lay entities may not own, employ, or control medical practices or interfere with clinical decisions. Second, the NASHP model regulates the friendly PC, this is that sort of straw physician, but also the MSO contractual terms without actually banning MSOs from existing. And the reason is that a lot of practices require a great deal of administrative support, especially in an era of value-based payment. There's a lot of data, there's a lot of contract negotiations, there's a lot of purchasing, there's a lot of reporting. It takes a lot of administrative apparatus and technological investment to be able to practice medicine in today's environment. And these MSOs are providing a needed service to these practices. However, there are some things that a MSO should not take control over, and that includes the type of clinical and business decisions that really start to implicate patient care. And so the NASHP model goes into some detail about what types of these clinical decisions or business decisions do implicate clinical care, as well as restricting the sort of conflicts of interest that occur between dual owners, people who are owners or compensated by both the MSO and by the practice. And so tries to get at some of the ways that we've seen MSOs exert control over these practices, again, through contract, by seizing control of their revenues, by disciplining and hiring and firing the staff, by setting work schedules, and by interfering with coding and diagnostic decisions as well. And then in addition, we've been hearing from clinicians that non-competes and gag clauses and other types of contractual terms of their employment or of their contracts with MSOs can often chill them from speaking out if they have concerns about the sort of the changes that a corporate manager might be making. And so to limit the use of non-compete clauses or ban them all outright for clinicians who are involved in patient care, as well as to not prevent them from speaking out if they have a patient care or professionalism concern. Some of these can also be extended to protect employed physicians, particularly in states that have a lot of physician employment by hospitals. So it's a much more limited set of protections, but it still would, again, prevent the hospital, the health system, from interfering with clinical decisions and also extend some of these contractual protections to them as well. Here we have an example of a bill that hasn't yet passed, but has been introduced. So Oregon has introduced Senate Bill 951. It sort of builds off a bill that was introduced last session in 2024. It's been reintroduced recently. And this bill would require licensed clinicians to retain de facto, which is sort of just a Latin legal way of saying actual ultimate control over their own medical practices. Again, so that clinician-owned medical practices cannot be controlled by the MSO or any other investor, and must retain ultimate authority over all business, administrative, and clinical decisions that affect the nature and quality of care in that practice, and then enumerates the types of contractual obligations that are considered either suspect or should be, again, retained in the control of the clinicians. It also bans or restricts numerous contracting or affiliate agreements that, again, create conflicts of interest, dual ownership or compensation between the professional corporation and the management service organization, stock transfer restriction agreements that tell clinicians what they can and can't do with their equity in their own practices, non-competes and non-disparagement, gag clauses. And all of this would be enforced, again, as an unlawful trade practice, so that someone who is affected, like an employed physician, or a member of a practice who sees some of these going on, could actually bring their own right of action to enforce violations that they detect in their own workplace. The final part of the model is to increase the transparency of ownership and control of healthcare entities. So as I mentioned at the beginning, the idea of transparency of ownership and control is that there really is no large-scale database that tracks ownership or control of a lot of these entities, particularly physician practices. So a lot of the work that Zirui and his colleagues are doing to provide this sort of penetration data is painstaking work, and it requires a lot of piecing together of proprietary and expensive databases and manual verification. And so one of the things that states could really do in this space is to require reporting by all healthcare entities in the state, including physician practices, to report information on their owners, on their controlling entities, the business structure of these entities, including the ultimate owner or controlling owner of the entity that manages them. It also would require the reporting of management service agreements, again, so not to be able to evade this through contractual means versus outright ownership, and to require that all healthcare entities do this not only sort of on a periodic basis, but upon any change to any of these ownership or control relationships, and make this available to the public. Patients want to know, is my doctor owned by a private equity company? And there's right now no way for them in most states to look that up. Certainly not at the national level. There is no way to be able to understand that. And researchers, again, don't even have access to this information. They have to kind of construct their own databases through lots of effort and resource. So the NASHP model would require healthcare market participants, that includes entities as well as physician practices, to report their ownership and control to a Department of Health or other health agency. And it would apply to group practices, to hospitals, health systems, nursing facilities, insurers, and PBMs. The NASHP model would say this can be reported annually, but also upon any change to the ownership or control. And then it specifies in some detail the types of elements of information that would be required in order to match up and actually identify the owners and the entities that are involved. And again, Massachusetts' most recent legislation provides really the first of its kind example of this. The provider registry that already exists in Massachusetts is really the only state that collects this information. And then the most recent legislation does enhance some of the reporting requirements under the provider registry. So for example, the Massachusetts law extends these reporting requirements to significant equity investors, to real estate investment trusts, to management service organizations, and parent organizations, including out-of-state parent organizations and affiliates. The financial data that is required under the new Massachusetts model is quite comprehensive, as I mentioned, and involves comprehensive financial statements. So it's not just who's your owner, but like what is their flow of money, right? So how is the money flowing, and where are the assets being held? The frequency moves from biannually every 2 years to annually, as well as upon a material change notice. And then CHIA can require more frequent quarterly reporting if the owner or the investor is a private equity company. And then finally, enforcement, the penalties for non-compliance have been increased recently, and removes the cap on penalties, because we don't want to just make it the cost of doing business to evade reporting to the authorities. And there are other sort of conditions attached to being compliant with your ownership reporting information. And that is, for example, the Department of Public Health now can consider compliance in their determination of need applications, as well as in the cost and market impact review. If they're looking at a transaction involving one of these entities, one of the considerations might be the extent to which compliance with the provider registry has been approved. So with that, I'm going to stop and just sort of open it up. I think we're probably, there's probably questions in the chat that I want to get to.
Thank you so much, Ziri and Erin. Wow, what a riveting presentation. If your mind is spinning, you're not alone, because mine is too. I'm still trying to process the vast amount of data here that was shared. And I just want to thank both of our presenters for sharing. Ziri, thank you for framing the issue so well, and also sharing the specific impact that private equity acquisition is having on the lives of patients and on the prices that we are all paying in some form. And then Erin, thank you for framing up and sharing the details on the legal landscape and what states are doing to try and address this issue. You mentioned something that really stuck out to me, and which is that patients want to know whether their hospital or clinic is a private equity owned hospital. And then you mentioned that it's really hard for folks to know this. And I know Zuri and team have developed this really comprehensive database, but they've worked really hard with their colleagues across the country to do this. And I guess I'm just wondering to both of you to ask this: do you think we're getting closer? When might we be at a place where patients and family members can actually tell whether a clinic or hospital that they're visiting or a loved one's visiting is one that's owned by a private equity firm?
Well, great question, Hussein. Thank you, Erin, for that incredibly informative summary of all of those policy directions. One of the desires of many state public officials is to know first who got bought out, where, and when in their state. And at the federal level, the Biden administration did move to publicly list the ownership status of nursing homes, including by private equity firms. Other aspects of healthcare delivery have not undergone the same requirement in terms of ownership, publicly posting the ownership. But at the state level, as Erin mentioned, an example like Massachusetts could provide a pathway towards gathering information around acquisitions. These disclosure requirements would enable a state government to potentially publicly reveal the private equity ownership or other corporate ownership status of healthcare providers. So that, from the disclosure of information comes the ability to make that information public. So this could come down the road.
Thanks, Zirui. And I guess I'll turn it to you, Erin. Do you think that that's kind of what we're going to be seeing in Massachusetts and perhaps in Oregon as well, like as we get more disclosure? And does that really mean that maybe we need more states to get into the game here? Because I was thinking about Zuri's map. There was a big high concentration of hospitals and clinics in Texas, but I'm not really sure what their state policy landscape looks like there. So I'm glad to see that Massachusetts and perhaps Oregon are stepping up here, but it did seem like it would require a lot of infrastructure, funding, data expertise. So do you foresee that Massachusetts will be releasing some of this information about ownership and providing some transparency? And then maybe as a twofer, do you think that, how are you seeing the landscape evolve for other states facing this issue?
Yeah, I think that, Massachusetts definitely part of the legislation is anticipates being able to make some of that information part of the annual report that is made in terms of, to the public and to the policymakers that are overseeing the healthcare market. But I think that, Massachusetts is pretty far ahead and is really the first state to do this. And so I think a lot of other states are probably watching to see sort of what is the resource burden, how does compliance look, what can they learn from the experience? Because I think a lot of other states are obviously interested in that ownership transparency tool, but worried that they don't have necessarily the infrastructure to collect that data, to verify it, to audit it, to make sure it's clean, to make sure it's accurate, and then to make it available in a usable, searchable way for the public, and for others who might be interested, like researchers. But I do think that many states, it's one thing we see in state policy is if one state can do something and demonstrate sort of the proof of concept, other states usually jump on board pretty quickly. And so again, it sort of depends on the politics of the state, but the idea of transparency has a bipartisan resonance. So there may be, for example, more interest among traditionally red states for ownership transparency than perhaps in strong forms of market oversight, for example. But I don't have a sense of like whether we'll see like, a wave across the country under what time frame. But my hope is that, again, other states will follow Massachusetts' lead in pretty short order.
Thanks, Erin. And you mentioned the bipartisan nature of private equity. We know there's been quite a few congressional investigations on this topic. And I wondered, could you share a little bit about the national landscape for private equity legislation? Is there any hope on the horizon here?
Yeah, so I mean, there was particularly under the Biden administration, the tri-agency request for information that came in last year. That HHS just released a report at the end of the sort of waiting days of the Biden administration, sort of summarizing what was learned by the agency in that RFI, including a lot of the data and the evidence that Zirui is an author of, but also cited in his presentation. And then I think the part that's interesting about that HHS report is also the sort of case studies, the comments, the personal experiences of clinicians and of patients who've seen sort of firsthand what the sort of corporate transformation of their own practice has looked like and what it has meant for them. And I think that's in some ways some of the texture that the administration was using to build a case to motivate further legislation or further action. So on the congressional side, I think that there is sort of interest in private equity, but the sort of new administration and the new majorities, the slim majorities in the House and the Senate by the Republicans, I think makes it a little bit unclear as to what a lot of these priorities, how strong there is how strong of an interest there is in regulating private equity or other forms of consolidation in the healthcare space. I think it remains to be seen, for example, whether or not the FTC is going to continue its investigation into the types of private equity roll-ups on a competition basis that it started with the U.S. Anesthesia Partners case in Texas, part of which just settled this past, recently. Again, it's hard to tell how strong of a priority this is going to be moving forward. But you're right that there is at least some efforts to lay the groundwork. And I think that's one of the reasons we observe that federal policy tends to move slower than state policy.
Thanks, Erin. I know we had a flurry of questions in the chat and in the Q&A. I just want to thank Zirui in particular for responding to many of them furiously. So thank you, Zirui, and hopefully the audience has been able to see those responses. I think we're running out of time here, and maybe I'll try to ask one last question if that's okay, Leah. And so I'll open this up to either. I know the forum here with the Center for Bioethics has a focus on ethics. And this last question from a participant is interesting. The question is, should physicians or PE-owned physician groups disclose their PE status as a conflict of interest? And perhaps I might add, is there like an ethical obligation, would we say, to disclose that? Or are we going a little too far here to say that that sort of disclosure is something that is, necessary or important for patients and families to know about in advance? So, Zirui, I'll let you go first.
Thanks. It's a really interesting question and a highly important one. Not being an ethicist, I'm not sure exactly what the right angle is for approaching this question. I think one fact that has emerged in recent years is that the intention of the initial private equity acquisition can vary. So I had noted that in the vast majority of cases, especially in leveraged buyouts, placing debt onto an acquired entity allows you to leverage your dollar further, but to buy more healthcare providers in the short term and to turn those around more quickly for profit motives. And if we were to generalize that model across all private equity acquisitions, it probably would be a little bit unfair. Not only is there the small sliver of distressed investing, as I noted, there are also more acquisitions where the initial private equity investment is more for growing a small practice or growing an innovative way of doing things. It's much more like venture capital or so-called growth capital than it is an extractive leveraged buyout for a quick turn, a quick quick sale. So if it is more for growth, to build a new idea or to give money to advance a new way of delivering care, such as in behavioral health or in cardiology or something like that in a subspecialty, then those initial investments could do good. But thus far, it's sort of unobservable in a broad sense. These are anecdotes. I think they are compelling anecdotes. These are anecdotes that teach us that that private equity is not monolithic, but they haven't been rigorously studied. So it's really hard to know how good were those growth dollars? What impact did they have? But if they were for the purposes of growing a startup idea or taking a risk as a venture investment, then sometimes what happens is that when they succeed, the smaller thing becomes a bigger, more successful operation, and then it gets acquired by a larger corporate entity, whether it's a private equity firm or a private equity for-profit corporate entity. That second acquisition now makes the initial growth investment less meaningful in that second stage. It goes from something with an initial growth investment to now just another item in the portfolio of a much larger private firm. And so it could lose its flavor, it could lose its uniqueness that were supported or nurtured by the initial private equity financing. And so this question of the ethics of disclosure, I think, again, not being an ethicist, invokes the sense of an assumption about the intentionality of the dollars. But I'm just trying to convey that the intentionality is complicated and it's not all monolithic. And I think that affects how we think about disclosure. I mean, obviously, in some simple sense, disclosure is helpful. Transparency is beneficial, as Erin noted. But if we take one step further, we think, what will patients and families do with that information? Will they be scared by it, appropriately concerned by it, or disproportionately scared by it if the intention doesn't fit the concern? So I don't know, but
Thank you for that thoughtful
Pick up on
response. I saw Erin come off here, but Erin, give you the last word. What do you
Yeah,
think?
just I think Zuri's last point is also well taken. I think that regulatory ownership reporting is more useful, and it's then an ethical obligation because again, it puts a lot on the patients and the families, and we already disclose so much to them. And what are they supposed to do with that information? Yes, there are some who will be super motivated by that information, but it also puts, I think, a lot of burden on them without necessarily being able to explain the meaning of what that entails. So like putting it in a database that's searchable, great. Forcing every encounter to be, to be involved in this disclosure, it's just like going to be another HIPAA form, right? So.
Thanks, Erin. Well, it's been a treat to moderate this conversation. I'm going to turn it back to you, Leah.
Thank you. And thank you for teaching us so much and also proposing some solutions. It's always good when we end with that optimism of what we might do going forward. And I invite everyone to join us in March, on March 7th, for Ethics and Regulation of AI in Healthcare. And thank you for your time this afternoon.
thank you, Leah. Thank you, Hussein.